Lovely. So welcome everybody for joining us today for this seminar with Associate Professor Prof Gebauer. We are very proud to have him as part of the MAG expert witness panel, providing IME services to us. He's been a dermatologist since 1992. And he has done some amazing studies. If you Google him, it's really very, very impressive in the fields of industrial dermatitis, in acne, and a number of other research studies. He's participated and contributed in over 40 clinical trials. He's widely published. His IME reports are excellent, and he's also a really, really nice guy. So, he sits on numerous boards and is well regarded as an expert within his field, so we're very lucky to have him. May I ask that when you join, if you could please keep your microphone muted. If you don't know how to do that, hover your cursor over the bottom of the screen and there's a thing that looks like an old-fashioned microphone. Click on it and that will mute it. The reason I ask you to do that is so that any sound in your home or office won't interrupt the presentation or cause any feedback or noise over the top of the recording. After the seminar is finished, there will be time for you to ask any questions of Dr. Gebauer, or you can write questions in the chat. And within about a day, you should receive a copy of the recording. Thank you so much, and over to you, Professor Gebauer.
Hopefully you can hear me. Clearly Michelle doesn't know me because she said some nice things about me. I understand it's predominantly a non-medical audience, and I'm one of these people that generally I do a lot of teaching for doctors and students. So I have a habit of saying, if you don't get anything out of it, it's your fault. Ask questions. I'm a dermatologist, so the MBBS means I did a medical degree. I did the old 6-year course. FACD means Fellow of the Australasian College of Dermatology, which means I'm a specialist dermatologist trained in Australia. FACP means I'm a fellow of the College of Phlebologists, that sometime I got bored and did another specialty degree on leg veins and a few other things. And OAM means somebody like me. I'm a general clinical dermatologist. I have an academic position, which sounds posy, but means very little. When I got into all this stuff was many, many years ago when I just qualified. One of my bosses was being sued. And nobody would touch the case because he was the god of dermatology and he was one of the college presidents, and everyone went, ah. And a company cold called me and said, look, will you take this brief against Dr. X? So I rang up Dr. X and said, what are we going to do here? And he said, well, someone's going to have to take it. So will you take the case against me? So it started from that. And also part of my training, I did a whole year in industrial dermatology. This is my disclaimer. You're normally used to something with a whole bunch of company logos. They leave it up for so long that you can't read any of it. And this is me saying, look, I apologize if I offend anyone or say something. I do mumble and occasionally I swear. I'll try not to.
Not me lah. This
is a little in-joke. This is the dermatology unit for Copenhagen. So nothing's changed. This was back in 1587. Dermatologists have a huge chip on their shoulder. They're the least important specialists in the medical hierarchy. We come after the cleaners. But the problem is everyone's going to get a skin problem. Everyone's going to have some sort of issue. And in the end, you will see a dermatologist. And when you've been scratching for days and can't sleep, you'll be very grateful that we exist. But nothing's changed in the medical hierarchy. This is how we get treated. Dermatology is an interesting thing. There's a bit of science, but it's all about observation. I've got a photographic memory. I'm no good at maths. I can't sing. There's lots of things I can't do. But as a dermatologist, you look at this and you say, how many fish are there? And most people don't even see the fish. So what we do is pattern recognition. And the story is also usually quite important. But frequently the patients always want to tell us some other story, not the story we want. So when it comes to work-related matters, this is usually how it starts off. They come in and they want to show me things. I've got 350 pages of waffle to go through and try to tease out what's actually relevant. And unfortunately, because you're not dermatologists, the GP is not a dermatologist, they don't actually know what we want. So there's a little bit of just sitting down with people and working out what's going on. Just my past, Leon Wall was one of my mentors. I did an apprenticeship with him. I basically wrote his PhD for him. And we did the world's biggest study in occupational skin disease. And what came out of this particular issue was this post-occupational dermatitis concept. So we actually proved that this exists. So the analogy is that if you hurt your knee falling off a ladder, or if you hurt your back picking something up, it really doesn't matter what the medical practitioners do and how well we repair you. You are always permanently got a damaged knee and you always permanently have a damaged back. And what wasn't appreciated, and probably still is not appreciated, is that if you go into an occupation like you're a hairdresser or you're a cleaner and you developed a severe irritant contact dermatitis, that's basically where you've stripped off the skin barrier and wrecked your skin, that you never ever repair. So you can get better, but just like a back or a knee, that bit of skin is always subject to breaking down. And what frequently is not well understood, particularly in your industry, is I get these letters going, oh, look, this happened. Is it possible from something that happened 25 years ago? And the answer is, well, yes, it is always possible, but it's far more likely to be more recent. And equally, they've been out of the job for 2 days, 2 weeks, 2 months, and they still have a problem. A knee injury is going to take, you'll know better than me, 9 months, 6 months to get better. Skin's exactly the same. It takes ages to recover. You're never, ever going to be back to your normal self. And unfortunately, further studies that we did where we went and looked at these people and said, what happened? Let's say you're a hairdresser, you have to quit because you've got an allergic contact dermatitis to hair dye, then they go and open a cafe or they go and clean. So patients have a habit of going from one job to a very similar job which doesn't suit their skin. So they need to be handled preferably by the specialist, should be told, look, go into retail, become a lawyer, become an accountant, get out of chemicals. You are not designed for this particular job. And now you have a particular job with chemicals, get out of it altogether. But patients, in your case, clients, have a habit of going from one industry to the other, which are actually very, very similar. So this is stuff we proved 3,000 years ago, and it is still very current to what you and I see every day. So we always show the gruesome photos. This is not a gruesome photo for a dermatologist. I see this 3 times a day. This is called Pomflex. And Pomflex is just a big fancy Latin name for blisters. And there are 4 causes for this. One is they've stuck their hands in chlorine or fertilizer or herbicide, and they're called an irritant contact dermatitis. Irritant is where chemicals basically just eat your protective barrier. Very rarely allergic contact dermatitis. We'll talk about that a bit more. Allergy is actually quite uncommon. Out in the public, everybody talks about I'm allergic to this, I'm allergic to that. But when we come in and scientific evaluate, allergy is actually extremely uncommon. But by looking at someone's hands, you can't tell. I'd be going, this is pretty bad. I wonder what they did to upset this. There are some people who just do this anyway, and that's called constitutional. They're just prone to doing this, that every time they get stressed or every time they get into hot, sweaty weather or every time they get sick, they'll break out in blisters. And all of you would have had little blisters from time to time on your fingers, particularly in hot spring days, just 1 or 2. And this is just the extreme example. And occasionally this is actually driven by a fungus on their feet or fungus on their hands. And that's called an id reaction, as in the Wizard of Id. I have no idea what id means. It's something we've used for 3,000 years. These are another pair of hands, which is the more chronic, sort of long-standing. They're dry, they're cracked, they're split. There's some thickness, some fissuring there. Again, this could be psoriasis, this could be eczema. There is a condition known as hyperkeratotic hand dermatitis, which is where we sit on the fence and we don't want to make a diagnosis between irritant and psoriasis. They look similar. And there we have to delve in and work out what's the story, what's their occupation. These are all impossible to treat. Tests for dermatology are usually a total waste of time. About the only test that are of value is a thing called a skin scraping to exclude a fungus. The rare occasions, allergy patch testing, which is coming up. Blood tests, all these things that GPs do and a medical specialist do are a total waste of time. This is a biopsy of the skin, the top of the skin, and they're those little blisters. So you saw some massive blisters earlier, but these are the little blisters, and this is called spongiosis. So again, when GPs have done biopsies of patient skin, it's usually a punch biopsy, which is very difficult to interpret. The results gibberish, and it just leads to confusion. This is a foot of an underground mine site worker. So they slop around underground. And again, it helps if you know what these people do for a living. If it helps if you actually know what their occupation is. So this person works around in plastic boots, 12 hours to 16 hours a day. It's stinking hot underground. It's dripping wet. Their boots are full of highly alkaline solution water dripping off the wall. They can change their socks as much as they want. They can change the gloves, but they're just in this wet environment all the time. In the end, they just get foot rot. Occasionally allergic contact, commonly fungus because they're in and out of dongas, communal facilities. But when you look at this, you can't tell. You have to go through the process and do it all properly. Going to pattern recognition, this is the side of a face, and you see a very sharp linear line. You see this rash above. Eczema is the same as dermatitis. Eczema is Greek for bubbles again. Dermatitis is Latin for inflamed skin. I prefer rash. My Portuguese typist can print that a little bit quicker. But when you look, there's this very sharp cutoff, and sharp linear things are not natural. So there's something going on above the line with normal skin below the line. So when we see this sort of pattern, we start wondering, what does the patient put on? Is there a problem with sunlight? Because is there a collar? And some people are photosensitive because they're on fluid tablets or antifungal pills. Some people have an inherent photosensitivity. So why is there a linear line? This is man-made, this is external. This is actually somebody who's allergic to their aftershave, and he just, when he shaves, he rubs this aftershave on, which is highly fragranced, and that's why you get a sharp cutoff. But again, it just takes a bit of looking at. We look at the pattern and go, there's an outside thing going on here, and start looking. This is another mine site worker that came out of a gold mine, and he worked in a processing area where they were extracting the gold, and he was actually allergic to gold. And the gold salts were getting through his gloves onto his hands and causing this rash. Once we worked that out, he just moved to a nickel mine and he's fine. But again, you look at that and that's just rash. He's been scratching for ages. It's lumpy and bumpy. With his dark colored skin, he's going to end up with some permanent scarring. But again, looking at that, you won't know. You need a specialist dermatologist who's interested in industrial work that actually understands what's going on. I love this picture. This is one of these lovely, wonderful Australian citizens who are up in Bali and decided to go and get one of those so-called semi-permanent tattoos put on his chest. It was like the had the nice dragon, except the chemical that they use to semi-tattoo is PPD, which stands for paraphenylene diamine. So everything that's black is stained with PPD, which from his point of view, when he was in Bali, he had this incredibly itchy, uncomfortable rash. Problem is PPD is in everything black. He happens to be a mechanic. So all mechanical hoses are covered with PPD. All tires are covered with PPD. If he works in a place with conveyor belts, all the rubber is PPD. So he's just lost his job. He can't work in industry because he's going to be exposed. So he has to retrain and become a sparky or use his brain, which for him was a bit of a problem. So sometimes the origin of the problem is something domestic or social. But when we get to the industrial thing, it's because they have a pre-existing condition. So then where does the liability lie? So it's like someone who's 5'6" and you get them carrying bricks. In the end, their back's going to go. The argument, which is up to the lawyers and the clever people, is, was this person suitable for this work environment in the first place? And that's not their fault, but they've been subjected to stresses and strains, heavy weights on his back, so his back's gone. This guy's got an allergic reaction to something from his social life, but he's now handling that at work. So I can just write the reports, and I leave that to the lawyers and everyone else to work out exactly where does the blame lie, if you want to use that word, or how does that come about. So PPD is what's in your hair dye. This is just standard dermatitis, lumpy, bumpy, itchy as, quite extensive. This is a forearm. just a generic pattern. All rashes, particularly if you look at a close-up, look very similar. The question is why? Again, a linear streak. This one, they look like they've been hit by a jellyfish. Easy one for us, because you look like you've been whacked by a jellyfish. This patient happens to be a gardener. And this is Grevillea Robin-Gordon. Or if they're picking mangoes, a backpacker, same sort of thing, they get exposed. And all it takes is a brush. You just touch it, the sap from the plant gets on, soaks in, get an allergic contact. So how do we work this out? These are a couple of images of what I do as a thing called patch testing. I use the word allergy patch testing because it's a little bit more clear to the patients. If you want to be scientific, this is type 4 hypersensitivity testing. So there's two main groups of allergy testing. Most people know about prick testing, which is where they do the little needles and scratches on your forearm. A number of you would have had that test. That is a useful test if you have bad asthma and hay fever. It is a totally useless test if you have a rash. Unfortunately, GPs don't know what to do. They don't know who to send them to. And the allergist immunologists are towards the top of the academic pile, so they make the most noise and they get the inappropriate referrals. A number of allergists are starting to learn how to do allergy patch testing. I have a few colleagues that we've trained because there is an overlap between the two patient groups. So basically, each one of these is a chemical that goes on the disc. These chemicals are usually made in Sweden or Scandinavia. And they're pure, like if we're looking at a hairdresser, we're looking at all the individual chemicals that hairdresser uses, bleaches, peroxides, fastening solution, nickel, cobalt, etc. This is a different set where people have bought in a whole bunch of chemicals that they're using at work themselves, and we've put them on. This is a beautician. So she's got all the chemicals from hairdressing because she works in a hairdressing salon, all the beautician chemicals and all the things. So if you're a little girl, sometimes difficult to get all the patches on. These traditionally go on a Monday. They stay on your back for 2 days. You're not allowed to get your back wet. I don't want you to go to the gym. I don't want you to go for a run because you get hot and sweaty, they fall off. And if you're a tradesman and it's Perth and it's 43 degrees in the shade in that week, it's a problem. So sometimes you'll see they've had to tape extra bits on. And they come back on a Wednesday and we take them off and we look for a reaction. So some of the chemicals have different colors and you can see a massive big red lumpy bumpy thing here. So there's a bit of red around because I've just ripped the tapes off, and any of you have done waxing or put a Band-Aid on, as soon as you rip the Band-Aid off, you're going to get that instantaneous redness. So we wait, but this is a huge reaction to something. And I have a fridge full of these depending what industry you're in, whether we're looking at your feet because you're reacting to boots, or whether you're a hairdresser, or whether you're a beautician, or whether you're an electrician. Each individual series is created for the particular conditions that the person is using, but they do come as sets. So this is a screaming positive reaction. That may be, for example, a chemical called colophony. Colophony is the sticky stuff in Band-Aids and doesn't explain why an electrician has a hand dermatitis. So sometimes we'll find old history, sometimes we'll find the relevance. That's the skill of being around and having done this for a long time. The interpretation is the hardest part. And again, this is what they look like on a Friday. And sometimes it's a little bit hard because you can sort of see red there, but is it just because they've been scratching? Is that because they've got dermatitis? So although it is a test, it's not 100% foolproof. Frequently, it's difficult to interpret. Frequently, patients have washed the marks off. They haven't complied. They've gone to the gym. So it's like most tests in dermatology. You have to take it with a grain of salt, and there is an amount of interpretation required. So this is a big reaction to nickel salt. 14% of the female population is allergic to nickel. So if you happen to work in a bank, you have a hand dermatitis, is it that you have a previous existing nickel allergy from having cheap costume jewelry, or is it hands being aggravated by the fact that you're counting coins or you're handling coins, because coin counted machines are now pretty much universal? It's interpreting how much are they getting in their work, how reactive they are, and then it is just a subjective opinion, because we really don't know is it the work environment that they're picking up a little bit of nickel, or is it because they're using a nickel cigarette lighter, or their dog lead has a nickel handle? So I'll come to the end of my sort of little blurb. The reason I put this here is because dermatology is, on one hand, it's simple if you know what you're doing, and usually for us it's bleedingly obvious. To those that control workers' comp cases, I would say send them off to see somebody specialised quickly. I get patients sent to me for medical legal opinions. This is a full IEM, and they haven't even been properly fundamentally addressed. Something's a fungus, and they've been off work for months, years. The first thing I would say to case handlers, if someone's been off for a couple of months, get them to a dermatologist and get them properly assessed. It's going to be cheaper in the long run than just having them off. And I see patients who've seen the GP for a work certificate every fortnight. I have no idea what's going on. Why? It's beyond me. If they've got a problem with their skin and it's not settling down, get them to somebody who knows what they're talking about, because we're going to end up a whole heap quicker, a whole heap cheaper, and the patient's going to get back to work faster. Second bit is, we can tell you when you've got a problem. People come in and, you look at those hands and you think, oh my goodness. You go, well, that's going to be a problem. They're not going to be back at work for 4 months. And sometimes you'll get me on the phone going, look, this person needs to see someone and needs to be treated. I'm writing an IEM, so I can't treat them officially, but you need to get them to see somebody who will treat them. I'm based in WA. There is one dermatologist who'll do workers' comp. That's me. The reason it's me is because I've been doing it for years. I'm stuck with it. You guys pay less than my normal patients. You stuff me around. You don't pay for 6 months. And then you wonder why you can't get anyone to look after your patients. So there is an issue. So sometimes I have to write and go, look, I'm the only person who's going to take this case on, and I'm the IEM, because you cannot get anyone else to do it. And the reason you won't do it is because it just doesn't pay. If they pay a reasonable fee, I think we'll probably attract some of these younger millennials to actually do some work in this area. But you'll find that all the people you talk to, whether you're based in Sydney, Melbourne, they're all older than me. And there's going to be a real problem in a couple of years when we all go, because that skill level's going to disappear. But that's an industry-wide problem. And MAG and all those others at the top end need to look at that. Thirdly, it's not certainly not as clear cut as it seems, and you do need expertise, and sometimes we get it wrong. I just had a classic where I sent something like 3 cartons of documents, and I'm sure it was by their lawyer, with absolutely no referencing. Everything was hidden sort of on page 673 at the back, and it so happened that what the patient had told me was totally incorrect. So whether she has deluded, whether she is mad, or whether she lied, I can't say. But the documentary evidence that was hidden in the pack was totally different to what the patient told me. I can only go on what they tell me. I can go on documentation if I can find it. But we also do need some help. So if you've got clear dermatological records, mark it up, put it in a summary, make it easy, because that'll be to everyone's benefit. So when I wrote this report, and then 3 weeks later, I finally went through the 1,500 pages and found the references, I actually wrote another report, and then got told, oh, we're not interested in the secondary report because you've already reported, which I also found bizarre. Because the 2 reports I wrote were going, well, she told me this, but the paperwork says that. So I don't know who to believe. Anyway, over to you.
Thank you so much, Dr. Gebauer. That was actually very, very interesting. And I know it will be informative for the case managers and the people that have joined us today, and for those who will watch this recording in the future on our YouTube channel. What you spoke about most recently reminded me of a matter that came across my desk that I saw, where a child had been diagnosed by the GP with nail fungus, and had been treated with all manner of topical products which didn't work. And then in the end, the child was put on a chemical called griseofulvin, and then had to go and have blood tests every week. And it was really quite invasive. And this went on for something like 3 or 4 months. And then eventually the child was sent interstate to a dermatologist, there not being one where this child lived. And then the dermatologists diagnosed a thing called 20-nail dystrophy.
Yeah.
Long story short, what it actually turned out to be was psoriasis.
Mm.
So exactly what you're saying, if she'd been gotten to a dermatologist faster, all of those processes, including subjecting her to some fairly strong chemicals, wouldn't have occurred. And that we see that in workers' comp and other matters as well. The skin is, as you know, the skin is the largest organ in our body, and we can't function without it. So you guys are very important. People, would you like to ask any questions? You can unmute yourself to do so. No questions. Now, sometimes that happens, and it's usually because the presentation is quite comprehensive and now no one's got anything left to ask. Look, I thought that was excellent.
The problem with
Thank you
skin
so
is
much.
you can talk for days and days and days, and there's so many combinations, so many permutations. We've gone from people seeking liability for skin cancers, that's all stopped, but the ones I have is particularly based in the WA. We have a lot of mine site workers with terrible hands, you know, above ground, below ground, sort of support staff, cleaners, cooks, chefs, etc. The military are pretty simple because they don't, you know, most of that is just sort of tick box and just doing the forms. The ones that cause the most anguish are the legal cases where somebody's got a claim in for something that allegedly went wrong or didn't go wrong, whatever. And I find them the hardest. I can just basically write a report and just go, this is what I can see, this is what the patient said. None of these are ever clearly cut. It's always open to the lawyers, as I'll say, to come to some sort of arrangement to how is this going to get improved. But probably one of the other things is when you get a phone call, or maybe just leave the door open, that the dermatologist who's going to be writing a report can ring you and just go, actually, it's all wrong. It's not this. It needs to be like the 20-nail dystrophy one. They're rare, they're classic, they're only something a dermatologist will actually notice because no one else knows anything about it. And unfortunately, we have some very good occupational physicians, but this is just not their thing. They're great at telling you how much percentage of this and that and whatever, because that's what they do very well. But when it comes to making a diagnosis and getting people on a proper treatment plan, you probably need a competent dermatologist for that. And how you do it at your end, you know, I just see if patients are seeing their GP and it's every 2 weeks, there's another form. One of the insurers over here, the state-based one, used to just randomly pull every file that had been on workers' comp for 4 months and send them off. And I suspect it saved them a lot of money.
Yeah, good idea. Well, look, everybody, thank you so much for attending, and thank you very much for your time. Professor Gebauer, have a great rest of the day, everybody. Go and have a wonderful day. And we look forward to seeing you again.
If anyone's got a burning question and it comes to them, just direct it to me through Michelle.
Fantastic. Thank you so much.
Bye.
Bye.